Trudel, an associate professor at the Princess Margaret Cancer Centre in Toronto, Ontario, Canada. She'll share results from the randomized phase 3 DREAMM-8 study of, it's a mouthful, belantamab, mafodotin plus pomalidomide and dexamethasone compared to pomalidomide plus bortezomib and dexamethasone in relapsed or refractory multiple myeloma.
Thank you. You're right. It is a mouthful. So it's a pleasure to be here. And on behalf of my co-authors, I'm pleased to present the results of DREAMM-8, which, as mentioned, is a randomized phase 3 study of belantamab mafodotin, which is a first-in-class antibody-drug conjugate targeting BCMA in combination with pomalidomide and dexamethasone versus pomalidomide plus bortezomib and dexamethasone in relapsed refractory myeloma. So it is clear these days that treatment for newly diagnosed myeloma patient involves the use of triplets and or quadruplets therapies, incorporating proteasome inhibitors and immunomodulatory drugs and anti-CD38 antibodies. Thus, at first relapse, the majority of patients will be exposed to, and many will be refractory to these three primary myeloma drug classes. And as a result, we are in need of treatment strategies that incorporate new agents with novel mechanisms of action for first relapse and beyond. DREAMM-8 is an ongoing global randomized open-label study that accrued patients who were progressed on their last line of therapy, had received one or more prior lines of therapy, including lenalidomide, were anti-BCMA therapy and pomalidomide naive, and not intolerant or refractory to bortezomib. Overall, 302 patients were randomly allocated, 155 to BELA-PD or BPD, which consists of belantamab mafodotin, pomalidomide, and dexamethasone every 4 weeks, or 147 were allocated to PVD administered every 3 weeks, bortezomib, pomalidomide, and dexamethasone. Treatment was continued until disease progression, death, unacceptable toxicity, end of study, or withdrawal of consent. Patients were stratified based on prior lines of therapy or prior exposure to bortezomib or anti-CD38 monoclonal antibodies. The primary endpoint of the study is progression-free survival with key secondary endpoints including overall survival, MRD negativity rate, duration of response, and there were additional secondary endpoints. So the study met its primary endpoint of progression-free survival and a median follow-up of 21.8 months. The median progression-free survival for BELA-PD was not reached and was 12.7 months for PVD. The 12-month PFS was 71% versus 51% for BPD versus PVD, respectively. And this represents a clinically meaningful and statistically significant reduction in the risk of death of 48%. We see the Kaplan-Meier curves show an early and sustained separation in favor of BELA-PD, and the progression-free survival with a hazard ratio of less than 1 favored BELA-PD for all pre-specified subgroups, including those with high-risk cytogenetics, those that were refractory to lenalidomide and anti-CD38s. The treatment benefit was consistent across all efficacy endpoints, including complete response, MRD negativity at 10 to the minus 5, duration of response, investigator assessed progression-free survival 2, and overall survival, noting that the survival data still needs to mature, but the hazard ratio was 0.77. And the overall survival benefit came despite the use of effective anti-myeloma therapies, including anti-BCMA targeted therapy and anti-CD38s for patients who progressed on the PVD arm. This table provides a safety overview. And although there were numerically more patients who had grade 3 or 4 adverse events or serious adverse events in the BPD arm, when we adjust for time on treatment, the AEs were actually similar or lower in the BELA-PD arm. The discontinuation for fatal events was 11% in both arms, while discontinuation due to adverse events of any cause was also similar in both arms. Ocular events were managed with dose delays and modification, and these protocol pre-specified dose modifications led to a low discontinuation rates for ocular adverse events of 9%. So in conclusion, the treatment with Bela-PD significantly reduced the risk of progression-free events versus PVD with a hazard ratio of 0.52 in patients with relapsed refractory myeloma who've had one or more prior lines of therapy, including lenalidomide. In addition, BPD was associated with an early trend to overall survival, with overall survival follow-up ongoing. There was a greater depth and durability of responses and a PFS2 benefit. The safety and tolerability of BPD were consistent with that of the safety profile of the individual agents, and after the during the discussion, I'm happy to give more details about what the toxicities were that we observed, but certainly ocular events were frequent, manageable, reversible, and led to low treatment discontinuation and did not negatively impact quality of life. So taken together with the results of DREAMM-7, which combined belantamab with bortezomib and dexamethasone, the encore presentations actually being presented today, these data highlight the potential of belantamab containing triplets to address the unmet need of novel regimens to treat patients in myeloma with first relapse. With that, thank you for your attention.
Thank you very much, Dr. Trudel. We're now going to invite Dr. Oyeofi Odejide, an ASCO expert and assistant professor of medicine at the Dana-Farber Cancer Institute in Boston, Mass. She'll make a few additional comments about the significance of this research.
Thank you very much, Dr. Grillo. The findings of this DREAMM-8 trial are really striking and demonstrate that adding belantamab mafodotin to pomalidomide and dexamethasone is significantly more effective at stopping relapsed myeloma compared to current standard of care treatment. There have been several advances in the care of patients with myeloma over the past several years that involve the inclusion of multiple agents as frontline treatment for myeloma. So we have triplets or quadruplet treatment. While that has really improved outcomes for patients with myeloma, it also means that when patients relapse, they've often been exposed and may not respond as well to many anti-myeloma treatments. So there is an unmet need for novel combination therapies in the relapse setting. And belantamab, based on this finding, is really meeting that need squarely. Based on this findings of this study, belantamab plus pomalidomide and dexamethasone is poised to be a new treatment option potentially for patients who have relapsed or refractory myeloma.
Thank you, Dr. Odejide. This antibody-drug conjugate in the winning regimen, belantamab mafodotin, has had a very interesting history, having previously received FDA accelerated approval back in 2020 in multiple myeloma, but in a much later line setting, at least 4 prior drugs, whereas this study, it's a minimum of 1 prior lines of therapy. The FDA accelerated approval actually was withdrawn in 2022 because that prior trial in later line did not meet its primary endpoint. So looks like we will be looking toward using this antibody drug conjugate again in the future. So we